Dear viewers, welcome you all to our show, Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing mask and keeping distance with each other. Dear viewers, today our topic is magic of Ilizarov, and the part is Ilizarov in femur, the most important and most crucial part for the young surgeons. And we will discuss about the safe zone, the corticotomy, and the wire fixation of femur in a nutshell, all for femur. So don't miss our program. And our honorable speaker is the legendary Elizabeth surgeon in Bangladesh, Professor Mofakharul Bari sir. I would like to welcome Professor Mofakharul Bari sir to join our program. So
Thank you very
welcome
much
to our
for
show.
the introduction. Thank you very much. Okay, I'll join. I'm
Thank,
ready for talking regarding the Ilizarov in femur. Thank you very
thank you,
much.
sir. Thank you, sir. And we have also a very learned academic expert, and Professor Novikov, sir, from Russia, from Russian Institute of Ilizarov. And now I would like to request Professor Novikov, sir, to join with us. Hello, welcome, sir, to our show.
Thank you very much. Good afternoon, Olaf.
Good afternoon, sir. Dear viewers, today our topic is the Ilizarov and Ilizarov in femur. We face lots of problems, especially at the safe zone and where we'll do the corticotomy and how we fix the wear. Don't miss our program. I think you will get all the answers from our program today and from the legendary surgeon, Professor Mafakharul Bari sir. So I would like to request Professor Mafakharul Bari sir to start his presentation. Bari sir, please.
Thank you. Thank you. So can you see my slide?
Yeah,
Yes. Tanveer, can you see my slide?
yeah.
Okay.
Excellent.
Thank you very much, my dear colleague and viewers. Dear Tanveer, I'm going to talk on Ilizarov and femur, which is very important for the orthopedic surgeons. And especially today, I'll talk on femur because this is one of the crucial and most complicated in Ilizarov surgery. And for the young surgeons, if they know how to put the Ilizarov in femur, they will be able to do a very good surgery in femur by Ilizarov technique. And this is my training place. Most of the time, I'm trained up from Russia and different places of Russia. And this is the center, which is the orthopedic center, which is called the orthopedic capital in the world. Professor Ilizarov started his journey from this institute, and lots of foreigners are coming every year to get treatment and at the same time to do their fellowship here. And this is my institute where I spent more than 10 years here and did lot of Ilizarov surgeries. In the right side, this is all the faculties, and this is one of the biggest orthopedic center which is located in Dhaka. This is my private Ilizarov center where I'm doing a lot of Ilizarov surgeries here. And this is I myself. I feel proud because I am the honored professor of this center. And from there, I learned a lot of things from my mentor, Professor Shevtsov, who was the disciple of Ilizarov, who was the director of the center for more than 18 years. So if you talk about the Ilizarov, he's the man, he's the myth, the method, and the magician, an orthopedic inspiration and a orthopedician of nature. Now let us talk about the safe corridors of Jones. Safe corridors are defined as longitudinal regions through which wires or pins can be inserted safely, for they contain neither musculotendinous nor important neurovascular structures. These are easily identified in eccentric bones as regions where the bone can be palpated subcutaneously. So when you are going to put the Ilizarov of the femur, this is the way how you can keep your leg and thigh in by traction. See here the position of the femur in the first picture, the left side. You can see in the top in the right side and below the two pictures. So let us see the now how we can know the safe zones. If you don't know the safe zones, you will not be able to put the pins and wires. The iphysis is always covered by thick muscular envelope. The major neurovascular structures are located medially and posteriorly, and you can safely be approached over the anterolateral region. If you look at the picture on the right side, you can see the nerve, artery, and vein. And deep artery of the thigh, you can see the location. And the safest anatomical zones for the wear and pin insertion are from anterior around to direct lateral regions of the femur. In a nutshell, the medial side and the posterior side is a dangerous zone, and anterior and lateral side is a safe zone. And if you look at these two green solid lines, you can see here two green solid lines. This is represented by one cross section. This is cross section of the bone. For the anterior approach, you must palpate the anterior surface of the femur with your finger. And whenever you've identified your drill guides are inserted through this small incision, and the drill is carefully used to drill bicortically, that means anterior and posterior, and the drill is carefully used to drill bicortically, and you must pay attention so that you can't hit the sciatic nerve. If you look at this, here is the sciatic nerve in the posterior part. Then, for lateral approach, palpate the vastus lateralis. You should have to know the anatomy and surface anatomy, and you should have to palpate the lateral muscle valley of the vastus lateralis, and you can insert the pins as shown in the diagram. You can see here, and aiming to gain the purchase in the bone cortex. This is the cross section of the bone, and then to prevent transfixing nerves, vessel and tendons during the insertion of half pins, the following techniques is totally recommended, which you must follow yourself. Half pins, a small incision is made with a scalpel. This is the scalpel at the appropriate position for pin insertion. Blunt dissection, you widen the space, and then clamp is then opened to further separate the soft tissue so that you can put your shunt pins. The tissue protecting guide is then inserted along the tract and placed against the bone. Drilling is then performed with the appropriate size drill. Irrigate the cone saline to prevent the thermal necrosis. And half pins or wires are then inserted to similar fashion via a soft tissue protecting slip. You can see in the picture right side. And wires, during the insertion of the wires, you hit the skin and go up to the bone, and then you try to drill with pause. Sometimes you should give the pause to prevent thermal necrosis. And the wire is then inserted in a routine fashion. You can see how wire is inserting through the bone. And now let us see the levels. If you look at the femur, we have sectioned this femur in 4 cuts: 1, 2, 3, 4, and 5, and 6. If you look at the cut 1, which is at the level of the head, just below the trochanter, greater trochanter, look at this level. The recommended fixation is performed using 1/2 pins, 5.5, 6 mm, inserted from the anterolateral. I told you previously, this is the same zone to the posteromedial. And the second one, you can see here, second one, which is from posterolateral to anteromedial. And angle between them will be 30 to 40 degree. You can see in the picture here. If you look at the cut level 2, that is below the lesser trochanter, You see the pins, insertion of the half pin at this level is from lateral side to the anteromedial and posterior to the vastus lateralis, lateral side. Avoid the lateral cutaneous nerve of the thigh. If you look at the cut tree, that means just below the 7 centimeter or 8 centimeter below the lesser trochanter, insertion of the half pins at this level is from posterolateral to anteromedial through the vastus lateralis. Vastus lateralis here, you must identify that one. And at the time of insertion, you can see the muscle fibers needs to be opened with the artery forceps that I showed you earlier with their fibers to allow for knee motion. Alternatively, two wires can be inserted here, the first from the posterolateral to anteromedial, one through the lateral intermuscular septum, transfixing the vastus intermedius and the rectus femoris. The second one is placed in similar plane to the half pins. So if you look at the cut 4, that is almost middle of the femur. Look at these anterior and lateral quadrants, the safest for pins and wires. Anterior, this one, and lateral is the safest zone. Nothing to be worried here. One optional transosseous wire can be inserted in an oblique manner, in an oblique anteromedial to posterolateral, anteromedial to posterolateral, and second from the posterior posterolateral to anteromedial. The half pin is placed is more posterolateral position, directed more anteriorly and along the line of the anterior aspect of the lateral intermuscular septum. This is, I talked about the cut 4. Look at the cut 5. Placement of the wires. Nothing to be worried here. Pins and wires from posterolateral to anteromedial. This is in the cut 4, just like cut 4. Wires can be placed obliquely in the anterolateral. Here, dear friends, anterolateral to slightly posteromedial direction, existing along the anterior portion of the sartorius here. This is again placed to avoid the medial neurovascular structures. Now let us see the cut 6, lateral epicondyle. The first wire is inserted in distal femur, capturing the transcondyle. While you are putting your wire, this is the transcondyle area you should have to put in a transverse fashion. This direction will be here. We must pay attention so that wire does not impinge on the soft tissues and limit the knee motion. This is very important. So these are the anatomical cut. If you look at the left side, these are the muscles and the bones. If you look at this muscle configuration, this is the neck of the femur, trochanter. You can see here is the bone. These are all muscles sequentially. You can see neurovascular structures. Cut 2, also like that. In the left side, see the muscles and the bones. This is the cross section of the femur, and cut 3, just like that. All the muscles are to the left side. You can see left side. And see the neurovascular structures. Crossing of the wires here, you can see here. This is the crossing of the wires here. And in the cut 4 that I showed you earlier, femur and all the muscles and the neurovascular structures here. And this is in the region of the cut 5. And this is finally in the condylar region, lower third of the femur. And in case of femur, if you want to do a corticotomy, you can go for subtrochanteric region and at the same time distal metaphyseal region. And regarding the corticotomy, this is a low energy osteotomy with the preservation of periosteum, endosteum, and bone marrow. In choosing a corticotomy level, anatomic, biomechanical, and physiological factors must be considered. We must think about the anatomical factors should not be performed in the middle of the bone. And this is not all the time true. And we are doing a lot of cases, even then we are getting lots of callus formation if you go for middle of the bone. And corticotomy is suitable in between diaphysis and beginning of the metaphysis. Biomechanical factors, the bone segment must be large enough to accommodate 2 rings situated between bone and the bone transection. appropriate distance must be 4 to 6 centimeters from the joint. And there are lots of physiological factors that we shall have to pay attention. We must not destroy the periosteum. We must preserve the periosteum, which is a vital thing for bone callus formation. And we must also respect the endosteum. And at the same time, bone marrow. We should not destroy the local blood circulation. And the status of the local tissues as for example, scar from previous injury, infection, or previous surgery can interfere in true regeneration, that is osteogenesis. Cyst, porosis sometimes prevents for bone formation. And when you are doing corticotomy, we may do or we can have a lot of mistakes. So pay attention when you are doing corticotomy. Don't do a skin incision, large one, okay? And poor choice of corticotomy level. Don't use oversized osteotomy. Destructive hammering of the cortex, direct cutting of bone marrow canal, you should not do that. Injury to near vessels and nerves. That's why you keep in your mind all the time, look after all the vessels and nerves. And performance of twisting corticotomy maneuver before complete cutting of medial and lateral cortex. And sometimes you can do an incomplete corticotomy. And traumatic corticotomy is also not a good option. So before doing corticotomy, you should think yourself regarding the size of the corticotome. And we are using plain corticotome and serrated corticotome. So let us see one case. I would like to show you this one. Look from the back and the front. This young 15 years old boy came to my place with at the age of 3 or 4, he sustained injury, and as a result, deformity of the lower femur and deformity in the right femur. This is the case you can see here, and fresh case. And we have done this case yesterday, and you look at this. Whenever you are going to perform a femur Ilizarov applications, look, we have applied the traction. In this way, you can apply the traction. Then we have put the olive oil first direction. Here is the post-traumatic deformity. You can see this is the oblique. That's how we have put the wire oblique manner. And this is how we are hammering. You can see the tightening the wires. These are the sequential stages. And this is, you can see, next one, how we are putting the wires. This area is not so dangerous. If you are meticulous, if you are a little bit intelligent, you can put the wires. You can see here how we have put the wires. 3 wires here, the distal part of the femur. It's very easy. Only you must pay attention how we can put the wires. We have put one ring here, and we are putting the another ring here. Look at this here. These are the sequential stages. Look at this. So this is the how we are doing the introducing the wires. Next step you can see here, and after applying the wire, you should have to apply by dynamometer. Surrounding the force of the ring must be equal. So this is the position how we are introducing the wires. And look at this here. This is for the shunt spins. This is for the stab incision. For putting the shunt spins, we have put one ring here, another ring here, and this is in the middle area. That's why we are putting shunt spins here. But due to anatomical constraint, the upper part of the femur, it is better to put the shunt spins. Otherwise, in other ways, in different areas, you can put the wires. Whenever you have crossed the first cortex and the second cortex, then you hit the wire just so that you don't have any problem with the neurovascular structures here and the skin also. So now see the putting of the wires from this is your second ring. Now I am, whenever you are putting the wires, you see here, this is with saline water, and assistant is pouring all the time so that you can avoid thermal necrosis of the bones. So these are the principles and philosophy of the Ilizarov. Only multiple wires, biocompatible wires. We are putting this one from the lateral side to medial side. Whenever you cross the first cortex and second cortex, then you hammer the wire gently so that you can go out through the skin, and you can apply this, you can tighten this with the ring. So now, dear friend, you can see here, this is the shunt spins. We have applied two ring here. This is the drilling of the shunt spins. This is the, we have put the shunt spins here. Now see the shunt spins here. You must cross a little bit the second cortex. And this is, we are just doing a little bit, weakening the bone for going for osteotomy here. Osteotomy. Here, this is the osteotomy to correct the opening wedge osteotomy. So next, you can see here the, and for doing osteotomy, we are weakening the bone from the medial side. See here, this is cutting for the angular osteotome, cutting there. Before that, I have weakened the, with drill bit, 3.5 or 4.5 you can use. You weaken the medial side for cutting the this medial side with the osteotome. So this is, I am weakening the bone. Now your osteotome is inside. Now whenever you have touched the bone, you gently then hammer the osteotome with your hammer. With your hammer. See, this is just gently, and under C-arm control, you can see then which way you're going. Okay. So you have done this. You finish your corticotome here from the medial side, opening wedge. You don't need to go to the second cortex. And this one must be parallel to the second ring, so that when you are opening, it will just like a V-shaped. And see, the assistants are widening this one, just pulling the first ring in between the first and the second ring. And then, look, the gentle hammer, what I'm doing here, gentle hammer, that is, you must keep it in mind, hand and eye, and your mind, whether you are hitting in the proper place or not. And then, see, look at this. When you have done, this is your widening space. And this condyle is up. When you will go for distraction, it will widen. It will just like a V shape, and this will come down. This is the area, with the traction area. And then with hinges, 90 hinges we have put here. And then you can see here, this is the final position of the femur, final position of the femur. And this is, you can see, monofocal bone transport corticotomy. And this is bifocal, 2 times you can do degenerative bone formation. And you can see here, the case that was done in India. I am doing the operation in Bangalore Ramaya Hospital. I'm doing corticotomy in the femur. You can see here with hammer, with gentle hammer, and you must know the anatomy from the lateral side. Lateral side, I am hammering, and after hammering, before that we have put the hinges so that you can control the corticotomy area with hinges. If you put the hinge fast and they do the corticotomy and just loosen the hinge, then there will be no displacement. Then I'm doing the corticotomy here. You see, this is in India, and at the same time pouring the saline, keeping the thermal area, cool. This is myself, my friend Dr. Harshad here, and I was doing their surgery in Ramaya Medical College 5 years back. Now, see, just when you are putting your osteotome, you just move yourself, and then after that you loosen the hinge, and you can see the whether you have done the corticotome nicely or not. Now we are unlocking the hinges. See, unlocking the hinges. In the left side, you can see we are unlocking the hinges, and a little gentle motion that will create you that you have done the osteotomy, and you will feel yourself, there's a movement of the bone, and you will feel yourself that you have done the right way corticotomy of the femur. So you can do any part. It's better to do in the subtrochanteric region and the distal, metaphyseal, and diaphyseal region in the distal part of the femur. Now, Ilizarov stability with shunt spins, pre-drilling necessary for prevention of thermal necrosis and long-term retentioning and loosening. Increased diameter, geometric increase, that means 4.5, 5.5 of 6 mm pins. Biomechanically, hybrid frame less stable. I-beam is lost. But due to anatomical constraint, you can use shunt spins in the proximal part of the femur. So, dear friends, before going to do any surgery in the femur, your trolley must be like that. This is the space, recess, creating a space so that your thigh bone is here, and this is your cot. Space like that, and see here, the patient is moving his, can move his thigh to the, this is the space that he can put his thigh here. Next, you can see here how he is doing exercises. There's the special cord. If you don't have this kind of cord, you cannot do any Ilizarov surgery for thigh. This is very important. Without this type of bed, it will be discomfort for the patient for lying down. Now see how patient is, sorry, this is ups and down, doing exercise with special cord with recess. This is Ilizarov frame in the thigh. How patient is doing exercises. These are the very important things of the Ilizarov surgery. And you can see different. There are a lot of tidbits. Patient doing exercises with a special cord. See here, thigh, leg, and femur. You must pay attention regarding the bed, special bed, whenever you are putting Ilizarov apparatus in the thigh. So you can see here, whole leg, thigh, and that one is in the hand. These are the apparatus in a different way. Now, a little bit slow. A little bit slow. Now, I would like to share you some case illustrations. I can show you some. Look at this. 11 years old boy, fracture neck femur, left side. Of course, you can do it with screws. This is Delvet type 2. Look at this. I have put multiple K-wires. Before putting the K-wires, you must reduce the fracture under CRM control, and see after 6 months follow-up. And patient can squat and without any pain. And this is before, this is only after 6 months follow-up. Look at this. Central line, Kelvin line, all are okay. And this is published in American Journal Metcalfe. C. Coxavara. Look at this one, Coxavara. See, shortening with Coxavara, 2 centimeter LLD. I am showing only the femur. This is, I have corrected double osteotomy here, neck shaped angle, and here for lengthening. This is the only K wires, only Ilizarov wires, no pins here. And this is after 1 and 5 months follow-up. Look at this, the angle corrected here, and the lengthening degenerate bone of here proximally and distally. This is the final view you can see here after removing the apparatus. This is the case you see. It was else were done outside my country with infection. Young 11 years old boy came, and then we started. He has done this operation in outside my country. There was a discharging sinus, came to my place, and then I removed that one. I put this is Bari apparatus, I called it. See the design of this apparatus. I put one shunt here and lot of multiple K wires and nothing else. Remove the screws, and then this, look at this, final radiograph after the treatment with the only the K wires. Now, 19 years old girl, 3 centimeter shortening, sequelae of neonatal hip sepsis. Again, talking with the hip and the femur. Look at this left side and right side. Only 19 years old girl, beautiful girl, 3 centimeter shortening, painful hip. This is high up. Then, what we have done? PSO. Look at this. Valgus osteotomy here. Adduction done. Then, at the level of touching point with the ischium and the bone, valgus osteotomy, and then varus osteotomy to make the biomechanical axis. Look at this. This is valgus and varus for lengthening, and then pressure to the Ilizarov apparatus in the hip and the thigh. And you can see here back view. This is after removal of the apparatus, and this is you can see healed here. And this here, this biomechanical axis is passed through the SI joint. This is the SI joint. See tendon is negative now. See the points and abduction of the right hip. This is PSO. This is also published in a medical journal. Now look at this subtrochanteric fracture, 2 months old, 42 years old man. You have other options. You can do plate screw, whatever you like, bone grafting. But whenever Ilizarov in your hand, this kind of fracture, 2 months old, you can do beautifully correct the deformity. And look at this, put the 2 shunts, only 2 shunts, and here only reduced and ring here. See here the 2 shunt pins and 3 rings. And what this is before, this is after full consolidation. You can see here. You can see here, this is here, full consolidation, beautifully corrected the deformity. And another one you can see, rightly you can do after the trauma, go for interlocking nail, it's okay. But patient came to my place with interlocking nail and infection, discharging sinus here all the time, suffering long time. Then what I did, I decided to remove the interlocking nail and then put the Ilizarov. Everywhere you can see, this is the middle third of the femur, only the wires, and wires. Even I have not used shunts here. You can put shunts here, and there is very good massive callus formation here you can see. This is after 2 months. And this is the final radiograph almost before dismounting the apparatus. You can see good callus formation, no infection here, only after 3 months. And these are my fellows from India and Malaysia. And this patient, look at this, with infection, interlocking lane, good healing, with Ilizarov apparatus after 7 months follow-up. So, dear friend, see, this is a very difficult case. A policeman, he was treated elsewhere with bone grafting, fibula grafting, but the screws and the plate is broken here. And deformity, you see angulation with shortening, how he was walking with varus and implant failure, LLD 3 centimeter. Then I have removed everything. Look at this, the distal, middle, and the proximal with shunts. Now patient with Ilizarov, everybody is telling cumbersome Ilizarov. What do you mean by cumbersome? If you put Ilizarov properly, if you follow the principle meticulously, then there will be no problem with the patient. This is not the Ilizarov technique of the doctor. Doctor, if he is not meticulous, is not intelligent, and at the same time, if he doesn't follow the principles, then he may invite lot of complications. So look at this. After 6 months with knee stiffness, because surgery was done 3 times here, including myself, 2 times before, and then there was a knee stiffness. For correcting the knee stiffness, I have done the Judas quadriceps plasty. This is straight knee, but with the knee stiffness. This was before. This is after 11 months follow-up. You can see the radiographic view before and after. These are the all challenging cases. So you can help the patient if you have the Ilizarov in your hand with proper knowledge and everything. Look at this, Judas quadriceps plasty. This is a big operation, but if surgeon is intelligent, if surgeon knows the approaches, 5-step surgery, then it is not so difficult for the surgeon to correct the knee stiffness, Judas quadriceps with a very fantastic operation. Now see, you can fold 90 degree, the knee is straight, the patient is happy. And this is a case, you see Gastilo 3A with big bone loss. Big bone loss, it was treated elsewhere with a big uniaxial fixator. And unfortunately, he came to my place with that uniaxial fixator. I have removed that one. Now you see what kind of damage, what kind of bones are here. He is a computer engineer. And then I put captured all the multiple fragments of the bones and put this with Ilizarov apparatus. Now you can see sequentially radiograph after 1 year. He can fold his knee up to 110 degree. This is after 7 months follow-up, 7 years follow-up. You can see 7 years follow-up. That multiple fragments became a one single bone. Very good consolidation here, dear friends. You can see here. Okay. Now the patient is walking with good bone stock in the distal part of the femur. Fantastic. And look at this. And this is a 3-year-old girl, chronic osteomyelitis. Again in the femur, 3 centimeter shortening. Look at this. Here, non-union. I have put one ring here, one ring here, and I have done the corticotomy here, and compression and distraction here. What happened? What happened? Baby with Ilizarov smiling face, and this is the before, this is the after. You can see the full length X-ray of the hip, knee, and ankle. And this is the girl after the removal of the apparatus. Now see how she is dancing. This is before, this is only after 6 months follow-up. And this is after 9 months specially dancing, who came to my place with non-union and shortening. Look at this. open supracondylar fracture in the right femur, gastilo 3A. Very difficult case, dear friends. Supracondylar fracture. In operation theater, see the first ring, see the second ring, arch and arch. And we are blocked from the medial side with telescopic rods. This is not difficult. This is not a difficult case. See, smiling patient and with wires only. With wires only. Here we have captured the tibia because this is nearby the joint. That's why worried of the femur and the difficult fracture. That's why I captured the upper end of the tibia. So this is before, this is only after 7 months follow-up. Look at this, dear friends. 15 years old boy, 13 centimeter LLD with hip fibrous ankylosis. See how this is 13 centimeter shortening of the femur and knee stiff. Then I decided to do what I decided to do. You see, I have arthrodest. This is walking, how he was walking. See with the toes, and he cannot bend his knee. This is before surgery. You see how he was walking. Now look at this. I have fixed how I have captured with the pins, hip, down the subtrochanteric osteotomy, made the biomechanics, and here one ring. This is the hinges, here another ring. And I have lengthened the tibia and femur also to overcome the 13 centimeter shortening. 13 centimeter shortening. And look, this full right extremity. Look at the back side. Look at the front side. And this is the biomechanics of the hip you can see here. See here. Osteotomy, the good callus formation. Axis is okay. Now patient is pain-free in lengthen the whole right inferior extremity. Look at this bowing of the whole femur. This is O type. Problem in the tibia and at the same time in the femur. Look at this. Smiling. A little bit difficult, but pain-free movement. Look from the front side. Look from the back side. This is all are possible due to Ilizarov with multiple Ilizarov wire or K wire, biocompatible. Look at this now. From back side, dear friends, after 3 years follow-up, beautifully corrected. From front, from back, in sitting, in lying condition. And of course, patient can squat very easily. This is also published in American Journal. Very difficult case. How to do corticotomy in the proximal. This was done elsewhere, not by me. Not proper putting of the Ilizarov ring and the wires. This was the situation. Infected one. Then I have done this case with this. I would like to show you here is the corticotomy seat, and I put the guide wire, very big space, all dead bones I have removed. This is the corticotomy done with 2 shunt pins here. This is the full big gap. That's why I put the guide wire to control the deviation. That is, when you are distracting, it will come down in this manner. Now look at this. This is the full consolidated distraction area, regenerate bone, good regenerate bone. And then this is the before this dismounting, full regenerate bone. Infection is held, no infection here. And this is before dismounting the apparatus. Now you can see here, this was like this, and this is fully consolidated, and this is the right thigh. Big gap. See, only I'm showing the femur. Again, corticotomy done here. You can see here corticotomy area, corticotomy. This is the gap. One ring here, and one arch here. Go for lengthening, and gradually we have lengthened, achieved the full regenerate bone, and this is the gap, and this is a clinical appearance of the patient after 6 months. This is also published in American Journal. This is, see, sometimes our surgeons, they are doing this gap with fibula grafting. Double fibula was taken. This is failed case of a 60 years old man with severe pain came to my place. Recently, I have done these cases. I have removed everything, all the screws, everything. It was difficult case. This is the fibula. And then what I have done, you see, this is, I have removed everything. Then I have put this with olive wires, the fibula. And now patient is giving full weight bear so that this fibula becomes a massive bone just like a femur later on. And I'm getting a good outcome, no infection here, and patient is doing the exercises. 60 years old man with infected lower limb of the femur with implant failure. Now he is getting day by day good outcome. Correction of the LLD published in American Journal. And these are the whatever your apparatus in the femur, in the tibia, patient is doing exercises. They are going up in the ladder. You can see, I always suggest my patient to go for exercises. The fundamental principle of Ilizarov methodology is load and motion. Whenever you apply load and motion, it will give you a good, very good callus formation and circulation in the limb. These are my fellows, foreign fellows. These are my Nigerian fellows, came to my place for learning Ilizarov in my country, in my center, Bari Ilizarov Orthopaedic Center. So it is Ilizarov is the origin.
Little bit network problem. I think both of our professor will connect soon with us. It was a great presentation. It was a magnificent presentation. I think all of the surgeons definitely will be benefited through this presentation. And due to network problem, Professor Bari sir is disconnected with us. So hope he will connect with us very soon. But I think it was a magnificent presentation, and it will helps a lot in all level doctors, for all level doctors, as because the femur is a very difficult thing to do. But after watching this presentation, I think it will be easier for everybody to do Ilizarov in femur, and to do in a right manner, and to do in a strict principle manner, and we should follow this principle to get the perfect result in case of Ilizarov. Now, I would like to request our honorable academic expert, Professor Novikov sir, to say something about the Ilizarov femur, to share his knowledge regarding this presentation, as because of Professor Bari sir is slightly disconnected with us. Professor Novikov sir, would you please share your valuable knowledge with us, please?
Let me say thank you very much for very excellent information about this segment of our body, lower extremities, femur in Ilizarov technique. I am very expressed with all of clinical cases. Start from beginning, any technique, any osteosynthesis need to know anatomical principles. And if you will start to work with good surgeon, good orthoped, you will very quickly follow our principles. And if you remember, Dr. Bari show first patient, and he show time during the surgery, he start from distal part. Usually, anywhere study, surgery must start from proximal part. But I agree with Dr. Bari. I am too. Just now, very excellent, because we work in one technique. When we apply first distal frame, more easy and more quickly, because we know distal frame must be parallel of line of knee joint, and you will not lose time. Then distal frame will show how you need to apply middle and proximal frame. And very important during surgery, put patient on the correct position on the table. Very, very important. Must be parallel to the floor, to the table, and when we pass wire, and Dr. Bari shows that, must think about good function of knee joint. Just now I support some girl after osteosynthesis by Ilizarov device, after simple fracture 1 year ago. Doctor put on Ilizarov frame, but not move knee joint during the surgery. Today we have very stiff knee joint. I cannot say we lost joint, but just now this is very big problem. And Dr. Bari show us very difficult cases. Please not start from that. Start from simple lengthening and simple correction. And I don't know how situation in Bangladesh. When you start correction deformity, please to do, in Russia we call telemetry. When in one radiography we can see all of joints, hip joint, knee joint, and ankle joint, we can decide about position of mat, biomechanical axis. And difficult case, please start when you finished few patient with simple elongation, 3-5 centimeters, and doctor like Bari with big experience can to do 10 and more centimeters lengthening. But for you, I recommend 3, maximum 5. Why? Because after 3-4 centimeters will come problem. If you know how go away from problem, yeah, you can continue it. By my philosophy now, better to do twice, more easy, more quickly, and with excellent perfect result, than once 8-10 centimeters, so long, 10 months in the frame, and so difficult. Please to do that if near with you doctor with experience. And For me, femur unique segment when we can do so many different techniques like chance pins. We can combine pass K-wire and pins. And one very important point, after surgery, any patient need attention, support from physiotherapist. Surgery is good, surgery is perfect, but this is not result. Result will only with excellent function. Please delegate this job for physiotherapist for function and walking, and during the treatment, please, I recommend contact with radiographist. After any radiography, ask opinions of radiologist. Maybe sometimes after 3-4 centimeters, condition of regeneration show better if sorry, if we will reduce speed of lengthening. Dr. Bari, I am very expressed about your cases. I'm very sorry. Help me, please.
Okay. Welcome, sir. I think it was a little bit network problem, so we missed your last slide. But it was really an excellent and magnificent presentation ever seen in my life. And I think all level doctors will be benefited by this presentation. And definitely, it was an excellent presentation. And thank you, sir. Thank you very much for showing everything what we want to learn from you, and showing all things ins and outs of femur. So I would like to give huge thanks from Orthopaedic Solution Academy to Professor Mofakkarul Bari, sir, for showing us the important things. So I have questions. Already Professor Navikam sir told us that he preferred to lengthen 3 to 5 centimeter maximum. But you have done more than 10 centimeter lengthening in your personal cases. If we do a multi-level corticotomy, then how much centimeter we can lengthen the bone?
Multi-level means you could go for two-level corticotomy. That is, we are telling two-level bifocal, but that is called trifocal. If you do the two-level corticotomy and the gap which you're just minimizing the gap, two-level corticotomy, that is called trifocal corticotomy, osteosynthesis. Because middle one is the gap, very big gap, as for example, 8 centimeter, 10 centimeter. If you want to fill up that gap, you can do the bifocal corticotomy. Rightly, Professor Novikov said 2 to 5 centimeter. By single corticotomy, I am doing all the time 6 centimeter. By one corticotomy, 6 centimeter. Okay. I am doing very good result. In children, getting very good result. For adults, sometimes 5 centimeter, 6 centimeter. If more than that, then I go for two-level corticotomy. That is, your gap is 10 centimeter, 12 centimeter. You must do a two-level corticotomy. As a result, you can minimize the time at the same time, and you can get a good consideration from two areas. So by single corticotomy, 5 to 6 centimeter. More than that, you should have to go over two-level corticotomy. Okay.
And can I a little bit follow Dr. Bari? This is depend, and I recommend little bit think about time of treatment. Just now we talk with Jan doctor. Jan doctor, please, if you want repeat experience of Bari, please use his experience, because not repeat and not start support patient with big shortening and to do in one's time. And for example, if we will touch patient with achondroplasia, for lengthening, for increase of height. We can touch, we can do with one osteotomy 7, 8, 10 centimeters without any problem, but we need check function of knee joint. If with some reason, same situation with achondroplasia, but old patient, lazy patient, and after 2, 3 centimeters coming contracture, knee joint is stiff, better stop. If after 8 centimeters we have excellent function, why not? We can continue. This is depend. What is better, centimeters or result with function of knee joint? Just now talk about generally. And during the treatment, if patient not follow instruction of doctor, if patient not to do physiotherapy, exercise, we immediately stop. I not believe patient, if patient, oh, after remove frame, everything will good, I will back function of knee joint. Never believe. Today show, tomorrow I will do distraction. And with my experience, better with big shortening, better twice touch. If we have patient, for example, 5, 6 centimeters shortening, yeah, we do in one stage, but this is depend. Straight, deformity, how many osteotomies, any case unique. And before surgery, we invite opinions, not only one surgeon. We show X-rays, Dr. Bari, Dr. Shevtsov, another, send and take opinions, and then after so many variants, we find better variants for patient.
That's great. Thank you, sir. Thank you. Thank you very much for sharing your valuable knowledge, sir. I have one more question, sir. In case of two-level corticotomy, can we start distraction in the same time?
Yes. You're asking me the question to me or Professor Novik?
Yes, sir. No, sir. To you, sir, Professor Mafakar Bari, sir.
Yes. For adult, I start at the same time, 5 or 6 days for adult. For children, after 1 day, 2 days I start for children. For children, because periosteum of the children is very thick. If you do delay, then there will be consideration. Distraction is painful. For the adult, I go for 5 to 6 days. If it is traumatic corticotomy, sometimes you are making lots of fragments. Then you can wait for 7, 8 days. Otherwise, 4, 5 days for adult, I have seen two-level corticotomy start same days. If pain increases after 2 or 3 days, then I go for slowly, 3 times a day, 3 times a day. Then if patient is already doesn't complain any pain, then I start again for 4 times a day. It depends on the painfulness situation of the patient. And after 10 days, I go for a X-ray. I see if there is a callus formation nicely, then I go always like that, 3 times or 4 times a day. If I see there is a scanty callus, then I stop for 1 or 2 days. Then again, I can go for lengthening. Sometimes for good regeneration, we go for autologous blood infiltration there in the area of corticotomy. You take the blood, 4 or 5 cc from the patient, then you can put there for good regeneration. You could do that. So it depends on case to case and man to man and age to age. It depends. And your experience also. It's a very big thing. If you have a good experience, long time I am working, so I have some experience that I can share with Professor Novik. He is also very good Ilizarov surgeon from the Ilizarov Center. Came to Dhaka 2 times. Huh?
And if Allah give a chance, I want next time show some cases with 2 level of lengthening. If we talk about adult patient, because sometimes amount of lengthening, if we talk about Ilizarov, classical Ilizarov technique, 1 millimeters for proximal part, 1 millimeters for distal part. This is too high speed for adult. And with two level, we have a chance. For example, start lengthening, start and finish with one speed. For example, 1.5, 1 millimeters in distal part, half millimeters in proximal part. And next day, we little bit decrease speed of lengthening in distal part and little bit increase speed lengthening of proximal part. The amount of lengthening absolutely same during the day. And this is like waves. Here we go to the minimum. In the proximal part, we go to the maximum. But totally same. When in proximal part, speed of lengthening will come to the maximum speed, then again go to down, here go to up, and same. And this is very interesting when you will see with this technique, you give chance for rest. When, for example, 1 millimeters for adult near the knee joint, we go to the minimum. After a few days, this area will take rest. Proximal part will to do job. Then go to the minimum, here go to the up. And very interesting technique. And next time with Dr. Bari, we will show.
Thank you, sir. Thank you very much. Professor Bari, sir, one last question from myself. That is there any role of a landmark of rectus femoris muscle or the border of the patella for wire fixation? Sometimes you told us about the rectus femoris muscles and to palpate the patella before wire fixation. Can you please tell us about these things?
In the femur, yes. Try to avoid the patellar region always. And if you divide the whole femur, proximal, middle, and distal, just above the patella, you don't need to touch the patella. Above the patella, you can go for wires. And lower one third, I've always used wires. I never use shunts. In lot of hybrid Ilizarov surgeons, they're hybrid. That is not Ilizarov. They're hybrid surgeons. They're using lots of shunts in the distal, even in the lower one third, and the middle, and the upper third. You just try to avoid the patella that I showed you, and which direction, very easy. In the lower third of the femur, only from the medial condyle 2 centimeters up, you can find the femoral vein. That is the area where you should have to avoid the wire, and the middle side of the distal femur. Otherwise, you don't need to think any kind of complications in case of femur. Even I told you that proximal and middle third and posterior, proximal, medial, and posterior side is dangerous. Otherwise, no other dangerous area in the femur. Only I don't know, and I have done a lot of cases in my life in the femur, not only in femur, in tibia, humerus, everywhere. Only you shall have to see with some senior surgeons, first 2, 3, 4, or 5 cases, then you will be able to do. What I have shown today, that is not enough. And whenever you will gather experience after doing 2 or 3 cases, you will be able to do fantastically in the femur. And the principles and the cot, a special cot for the femur. These are the things. Okay, thank you very much.
Thank you very much, sir. Thank you for your nice and brilliant presentation. I think it will help a lot for the junior doctors as well as the senior doctors also. And I would like to thank our honorable speaker, Professor Mofakharul Bari sir, and our honorable academic expert, Professor Navikov sir, for being with us. Hope we will see you in the next Friday with another topic, that is the magical Ilizarov. Till then, I'm Dr. Mohammad Tanvir Ashraf. Want to say bye-bye. And before that, I want to thank Raj TV for helping us to organize this sort of program, and definitely the Venata Pharmaceuticals Limited for sponsoring this program. And I'm Dr. Mohammad Tanvir Ashraf saying bye-bye from Orthopaedic Solution Academy today. Bye-bye.
Thank you very much. Bye-bye. Thank you very much.
You are watching Raj TV, Jagorone, Bangladesh.